Good evening, everybody. Thank you for joining us at Asia Society India's third virtual program. Asia Society's programs through our 14 centers have all now become virtual and global. And I'm Bunty Chand, the Chief Executive Officer of Asia Society India. Asia Society India began its virtual life with a series titled very optimistically, Overcoming the Pandemic India. And in the face of what we are now hearing, maybe it should have been living with the pandemic India. And but really what we are trying to do with the series here is to share with our global audience issues that are of peculiar challenge for India. And so we had done a program earlier on food security and the issues relating to the migrant labor. And so today's program addresses the challenges of gathering reliable data to assist in making informed public policy decisions in India. And what kind of data is required to help the country spring back from the lockdown? And what is the data that the public can trust? This is a challenge given that there is just a deluge of information available on the internet, social media, and television. And joining us today are two distinguished academics and researchers, Professor Shamika Ravi and Dr. Prabhat Jha. Professor Ravi is joining us from Delhi, and she's a senior fellow at Brookings and was a member of the Prime Minister's Economic Advisory Council and is also professor at the Indian School of Business. An economist, her daily tweets on India's march through the pandemic have exploded her Twitter following, and she is quite a favorite for the various media and TV channels. So Shamika, we are really grateful that you've been able to join us today. And Dr. Prabhat Jha is joining us from Canada, and Dr. Jha is an epidemiologist and endowed professor in global health and epidemiology at the Dalla, Lana School of Public Health and founder of the Center for Global Health Research at St. Michael's Hospital in Toronto. And he is the lead investigator of the Million Death Study in India. And as I reiterated earlier, I hope you will reference that in your conversation with us tonight. And thank you so much for taking the time to join us this evening, Dr. Jha. And a bit of housekeeping for our audience. All those of you who are joining us on Zoom, please leave your questions in the Q&A section. And for our audience on Facebook, please drop them in the comments section. And now what I'm going to do is I'm going to ask Shamika to begin the conversation, and she has a short presentation for us. So she'll share the presentation with us.
Thank you, Bunty. Thank you. Thank you for the invitation, also for the topic. We have been discussing the pandemic at different forums, and we have really not talked about the heart of it for researchers. It's mildly frustrating that we are having to grope in the dark because we, in some sense, are reading tea leaves. The nature of the data is very fragmented, and this is despite the fact the WHO is involved with this entire exercise in very complex and sort of comprehensive ways. But just simple things like defining COVID death rate would be a huge challenge. So when you start comparing countries, in many ways, we are comparing things which are measured very differently in different countries. So given that it's a dynamic problem, we are right in the middle of it all. I'll try to make some sense of the existing data. So I'm going to just start this presentation. Let me know if everyone can see this.
Yeah.
Okay, great. So I've titled the talk, What Do We Know? And let's start out by first acknowledging and accepting that we actually don't know very much because the nature of the data coming from different countries is very diverse. The study we have just finished, and it's basically at a journal. But I'd like to discuss one very simple aspect of the complexity. This graph is telling you that if we just divide the entire world according to the Civil Liberty Index, which is full democracies, flawed democracy, hybrid and authoritarian regimes, just look at the kind of deviations or fluctuations that we are seeing in the data across different regimes. So it is quite systematic if you see that in democracies, countries that we live in, there is considerable fluctuation and it is quite systematic. So when I have been analyzing data from China for over 3 months now, and let's say the death rate has not moved from 3.34 per million, now I have an answer as to perhaps it is because of the nature of the regime. And you can see this is true for many other countries, Iran, Yemen, Qatar, Russia. These are all countries that fall in the authoritarian regime. You can see Iceland, Belgium, Spain, very large, and these are deaths. These are deaths and the fluctuations in daily deaths. You can see that these countries have not only large numbers but very serious fluctuations in their measurements of death as well. So this is just to give you a sense of the data is not uniform by any measure. But let's try and make sense of what we know. Now, this is based on the Johns Hopkins, and I think they have done a fantastic job of starting out with really two keen researchers, pretty much like the rest of us across the world who are locked up in our houses. They started out with a very small group, and over time they built the capacity to put out pretty good, in fact, highly credible and verifiable data from across the world. And if you look at the hotspot countries, and I'm going to define them as countries with more than 50,000 cases, there is great variation. As you can see, of course, the US is still off the chart and still increasing. The bottom green line that the graph is India. And in India, as of last night, we have 56,351 cases. Now, individually, India has been moving in terms of the policy measures. But before that, let's also look at the death numbers. COVID deaths, this is across the world. Again, hotspot countries being defined here as countries with more than 3,000 deaths. Again, the US is off the chart, but you're seeing a lot of the OECD countries on the top right side of the graph. India is the bright green at the bottom. And we have, as of last night, a little under 1,900 deaths, registered deaths in COVID, because of COVID. So you can see that there is an enormous variation. India truly has very few recorded deaths from COVID. This is as of early March, and when the world started, and for us the world starts at when countries have reported, let's say, 300 deaths. The initial growth rate in India was very rapid. But, you know, in many ways, the government at the center as well as the states were very proactive that with such few numbers, they enacted very strong policies. And one of which, of course, was airlifting students from China and Iran and Italy and separating them in quarantine facilities, doing testing at the airports. Now, we're familiar with the high-profile cases of people jumping these, but, you know, on the whole, this was a very large exercise where a considerable amount of screening happened. Almost all states of the union implemented the Epidemics and Disease Act, which is an act that gives the state extraordinary powers in times of epidemics. So you can curtail people's movement, and you can do many things which are extraordinary. Then, of course, on the 29th of March, the growth rate really began to shoot up when the Tablighi Jamaat, the big congregation that happened in Delhi, with subsequent contact tracing taking us to about 16 states of the country within 2 days. After that, we saw a considerable rise. But you do know that from the 25th of March, a national lockdown was introduced, and the impact of that you see from April 6th. So from April 6th, there was a considerable flattening of the graph in terms of the overall caseload. And of course, the world has changed a lot since April 6th. So now we are growing at a rate where our active cases are doubling every 11 days. Now, if you start from the beginning, of course, there's considerable slowdown. So the suppression strategy, which a lockdown does entail, it has bought us time. It has bought us, more than 40 days. And of course, the idea is when you do delay and you buy time through such a large, stringent policy, what do you do with that time? And what we do know is that now every district of the country has dedicated COVID hospitals. We have fever clinics. We have doctors who have, who are designated doctors for COVID. Considerable quarantine facilities have been created at different district levels. We do know
Shamika,
that, yes.
sorry to interrupt, but the audience is asking if you can expand the PowerPoint to the full screen.
Oh, sure. Let's see. Okay.
Yeah, much better. Thank you.
Great. We do know that, many districts of the country, in fact, many states did not have labs until 3 months back. And we do know that states such as Nagaland and Manipur and many of the northeastern states, as of last 1.5 months, they all have diagnostic labs where COVID testing is happening. So what the suppression strategy did buy us time, and in that time, the government has built the capacity to really manage this crisis. But let's look at the existing data in terms of what has been the growth rate. On the left-hand side, you're seeing the daily, this is the 7-day moving average, because daily fluctuations are very enormous. It's good to smooth it and look at a 5-day or a 7-day moving average. And you see that after a considerable sort of flattening, now in the last about a week, we are seeing again an expansion. And this could be because of the relaxations after the first lockdown, when some amount of movement and essential services were allowed. And this is to be expected. I mean, this is going to just continue. And I'll, in a minute, also talk about why this might not be entirely devastating and why we need to have a context for this. On the right side panel, you're seeing what is happening to daily deaths. This is also rising. Now, as of the COVID death rate per million, we are seeing that, compared to countries in the OECD, if you look at Belgium, Spain, Italy, in fact, almost all Western European countries and the US, Canada, we're seeing that the death rate in India is considerably muted. I mean, it's about 1.4 per million people. And of course, there's enormous variation within the country, but it just tells you that these are very low death rates. And this is also borne out by looking at the data within, across hospitals. So if we look at hospital level data, we are seeing that the flow of patients this year with respiratory ailments are looking very similar to the flow of patients last year or the year before last for these months of March and April. So, the hospitals are not filling up with patients the way we are seeing in the OECD, the European countries and the US. So there is reason to believe that even though the measurement of COVID death rate varies a great deal, there is no standardized measurement. In the Indian case, the low mortality numbers are also borne out by the hospital numbers. This is comparing recoveries across the world. So when you say, have countries flattened the curve? Well, clearly Germany, South Korea, they have done a fantastic job because the overall numbers have flattened and recoveries have increased in very significant ways, and they have very few active cases now. Unlike these countries, we see that the US, UK, we're seeing India, we're seeing Canada. These are countries which are yet to see active decline in the active cases and massive increase in the recovery, which means that they are yet to flatten in terms of a reversal of the trend. We do see that in countries like France, Italy, and Spain, there is a flattening, but it's a very slow flattening if you compare it with, let's say, China. China truly is peculiar, and that's why the data issue keeps coming up, because it's almost like they fitted what we call in statistics the God's curve. This is the normal distribution, absolutely well fitted with zero fluctuations as of the last 8 weeks that I have been studying this. Which means either they have absolutely stopped testing, or there's something happening which I don't understand. But that's what the data looks like. Now, let's talk about India. Well, India is a very large country. It's like studying the entire European Union and trying to make projections for the entire continent. 1.38 billion people across all these big states. It's best to look at state level analysis. And what we do see here is that the all India trajectory is pretty much being determined by trajectories in few states. Maharashtra is clearly leading this with very large, it's an exponential increase still in terms of the active cases. And as of last night, they're just a little below 18,000 cases. But Gujarat isn't way behind either with 7,000 cases, though they are seeing relatively more recoveries, but the growth in terms of active numbers is still very significant. And more importantly, the death rate there is also pretty high. Delhi, while it is seeing an increasing active numbers, Delhi has managed to curtail or sort of stabilize its death rate. But you see that after initial success for the first few weeks, Delhi is seeing a very large second wave with an increase in the active cases. We are seeing something very similar in Tamil Nadu. Tamil Nadu had considerable success in the first 1 month, and as of the last 3 weeks now, we are seeing a very large increase in active cases. But again, just like Delhi, Tamil Nadu truly has very low mortality rates. Similarly with Haryana, Haryana did very well. In fact, Haryana and Kerala were going neck and neck if you just consider the way active cases were suppressed. But Haryana is seeing a big increase now. The states which are showing a big increase in recovery and either a stagnating or a declining active case, you see Rajasthan doing well. MP is struggling with high mortality, but there again, the active cases are beginning to decline and recovery is strong. Similarly in UP, Andhra Pradesh, Karnataka, Jammu Kashmir, and Telangana. And of course, Kerala is at the bottom left-hand side. We can say that Kerala has flattened its COVID graph because now they have single-digit active cases, and the recovery is what comprises the majority of the cases. So this is a snapshot of what's happening across the big states. But this is the day-to-day worry. What's happening to new cases on a day-to-day. And this is the 5-day moving average of new confirmed cases. And you can see that Maharashtra, the new confirmed cases is above 1,000. So Maharashtra is seeing 1,000 new cases every day as of the last few days. Gujarat is seeing just a little below 400, but it is still, these are new cases, so these are great cause of concern. Delhi is seeing big increases as well, about 350 new cases a day on an average. Tamil Nadu is seeing a big increase. The many other states like Rajasthan, MP, etc., beginning to stabilize. Several states have actually, they're seeing a decline. So once again, large country, huge variations, but there are some hotspots which are truly pulling up the national numbers in very big ways. This is just to see the mortality numbers, COVID death rate per million across states of India. Gujarat has almost 5 times the national average. And between Gujarat, Maharashtra, Delhi, and MP and West Bengal now, over the last 1 week, these are the states that are pulling up the overall death numbers in India. Delhi, you can see, has stabilized it despite having large numbers. It might be the fact that Delhi has the largest concentration of health infrastructure in the country, but it's also a management issue. I think Delhi is doing a far better job of suppressing the spread than, let's say, Gujarat or Maharashtra right now. But this is critical. This is telling you what is happening with testing. And this tells you the percentage of, or the number of confirmed positive cases for every 100 tests that are happening across the states of the country. Now, the truly worrying trends are, as you can see in Maharashtra, Gujarat, where with more and more additional tests, the positive rate is actually increasing, which seems to suggest that in Maharashtra and Gujarat, the infection is way ahead of what we know it from testing, which means they truly have to ramp up their overall testing considerably. In fact, if you compare Maharashtra and Tamil Nadu is actually testing much more than Maharashtra, despite having 1/3 the total number of cases as Maharashtra. So Tamil Nadu has seen a recent, let's say last couple of days, an increase, but over time, they have truly stayed ahead of the infection. If you see, overall, the percentage of positive for every 100 tests. Delhi and Madhya Pradesh are very high rates of confirmed per 100. And they aren't falling. It would be, in fact, right amount of appropriate testing would mean, and of course, as you know, in India, the protocol is, it's not random testing right now. It hasn't been. We typically have a contact tracing base. So in Delhi and MP, where the percentage of positive confirmed COVID cases for every 100 tests is around 8%, it's very high. And it hasn't fallen. It has remained high. Similarly for West Bengal. Telangana is very curious because they aren't putting out test data at all, and I think that's quite unfortunate. People need to know. There's a certain degree of public trust that is built when you put out this kind of data. But many states, and you can see Chhattisgarh, you can see Assam, Jammu Kashmir, Haryana, Odisha, you see Karnataka, Kerala. I mean, these are places where the infection is being captured through the testing, as you can see in terms of the percentage positive cases over time and over tests. A little bit because, at the end of the day, I am an economist. My big worry is about the economy. With the lockdown, an extended lockdown now, we are into lockdown 3. There is a huge rising opportunity cost to the economy. And I know the IMF projections are quite optimistic, but I have some doubts about it. I do think we have entered sort of a flat growth, about 0, but if this continues, the lockdown, and it's unlikely to be a switch where once the lockdown is lifted, the economy truly goes back to full capacity. It's going to take several months to go back to that level, which means we are seeing a contraction of about -2 to -3%, which is a very serious decline for an economy of $2,100 per capita per annum. So we are a low middle income country at best. But I suspect there might also be structural problems, which means people going back to their villages are unlikely. You might even see a decline in the labor force participation itself, which means the pressure on the fiscal is going to be more. People might seek jobs nearby through Narega, workfare programs, etc., which means industry is going to face a shortfall. You will see those distortions getting reflected, and these are long-term distortions. But the labor market, the informal sector is truly under deep duress right now, which also means, of course, with declining revenue, because the demand side is also under duress, many contracts are getting cancelled. And against a falling or a 0 revenue, honoring repayments is also going to be a serious problem, which means the NPAs in the credit market, they are going to rise and rise significantly. So I have been basically proposing, I've been basically recommending that we lift the lockdown in as many ways as we can, best to do it geographically, and to continuously that indeed 300 districts do not have a single case. So let's just open and go back to life as normal. Of course, life will not be normal because the new normal will mean that we have to take all possible precautions, not just at individual level, but industries, the firm level, the local governments, and it is a management problem. I do think that local governments, it's not a central government or even a state government. I truly think district administration needs to see that the civil administration, the public health department, and the police do work together, as we have seen in several of the successful districts in the country, and bring down this, the active cases to minimum. But it's going to take all of these efforts for a prolonged period of time. So I'll stop with that, and happy to take questions later on. Thank you very much.
Okay. Prabhat, do you have an immediate question, or would you like to make your presentation first?
Why don't I present and then we can take questions together?
Okay, great.
Okay. Morning. Can you see the screen now?
Yes, we can.
Okay, good. Good. What I'd like to do is very quickly build upon Shamika's excellent presentation to talk about what do we know and what do we need to know. And quickly, I'll run through some key features about the question, is infection spreading or slowing in India? And I want to focus on mortality because that is subject to far less of the biases that occur in testing. And then quickly touch upon the need for more science to enable better control. So one of the things to know about COVID, as we've determined, is that it is infectious, but not nearly as infectious as, for example, measles or polio. If you look at this scale, which is the number of people infected per infected case among the susceptibles, this is what we epidemiologists call the R naught. So COVID is estimated around something like 2. And the case fatality rate, and this is an older graph, is actually quite uncertain. And it does also mean that we don't really have a sense of what are the overall deaths going to be from COVID currently, given this uncertainty. So now this is flatten the curve. I think everyone has gotten the idea that what you want to do is prevent a peak from occurring and instead delay it and have it below the capacities that exist in the healthcare system. But this is not just theoretical. If you look at what happened in 1918, pandemic of influenza, there's a nice contrast between Philadelphia, which on around September 26th or 24th reported some cases. 3 days later, they held a big parade and the mayor didn't shut it down, and boom, up go the cases. By contrast, St. Louis had its first report around the just a couple of weeks later, and they immediately went into social distancing, and there they had a much flatter trajectory. So this is not a theoretical curve, it actually has been realized. Okay, so let me describe in terms of placing India in the context, what's happening with R naughts in different settings. So you can see this, it's a little hard. I think this is Germany that you see on top. I can't quite see that on mine. Austria, excuse me. So what you see here is estimates in these countries, which is very much what India would need, are what's called the effective R naught, meaning what's the daily numbers of people susceptible infected by one case. And the goal is to get below 1 so that basically the epidemic shrinks. So Austria now is below that level of 1 and now is reopening. And this is Germany, is it?
United Kingdom.
UK. So UK is not quite there, but it's on its way. And this is Canada, where we're on the cusp of falling below 1. And sorry, this is Canada, excuse me, where there was a big increase in the effective R naught in around March, and now it's coming just below 1. And even within Canada, there's strong variation. So some parts of the country, the Maritimes, are actually well below that. Now, one of the lessons learned is, as Shamika mentioned, the need for diligence. So this was Singapore very early on, did actually reduce their R naught below 1, but they had a large group of hidden infections among migrant communities, and they've had a big increase recently, and now they're struggling to bring it down. I'm sure they'll succeed to do so. What about in India? Well, in the absence of very good data, direct data that you would want, and the low levels of testing, then you need mathematical models. And the mathematical models, however, have been inconsistent in their findings about the impact of the lockdown in India. This one model suggests that before the lockdown and after, the effective R naught was substantially reduced, but not below 1. So the epidemic continues to grow. Another paper has examined the differences by state and suggests the lockdown has worked outside of Mumbai, that it had the effect outside of Mumbai, but in Mumbai and surrounding areas, less so. So this is a very similar curve to what was shown earlier. This is from the Financial Times. And this, however, focuses on mortality, and this is the cumulative deaths. And I think mortality is important because it doesn't, it's not subject to the biases of who gets tested, provided you're counting all the dead. And I'll come to that in a second. So as mentioned, the Indian trajectory of deaths, the cumulative deaths, is a shallower one than in the United States. And this is the Chinese plateauing that occurred. And the question is, India is going to go there, or will it go steadily up, but at a lower level than the US? Now, we've done some careful mortality forecasting for different countries. And one of the key conclusions is that where efforts have been taken seriously, it does lead to a lower epidemic. So this contrasts 3 US states: Washington state, which had the first cases reported, but which took action. And there you see a nice plateauing of the curve. California, which also did some serious efforts. And then, by contrast, New York, where the efforts were late. And you see the much higher curves. You can also use this to compare the mortality rates per million population across different countries. And you see enormous variation. There's more than a tenfold variation, let's say, between the Belgian rates and down to the German rates. And what are the reasons for those? In India, the mortality data are more scant, but they are pointing to a few common elements. So these are data from Mumbai, somewhat older, of April 10th. And it suggests also, like in high-income countries, most of the deaths that have occurred are in those above age, basically above age 50 or 60. And they involve comorbidity, meaning those with existing heart disease, diabetes, and kidney disease. And that's important in terms of thinking about mitigation. Now, the curious finding from Mumbai is that the overall numbers of deaths reported actually fell in March versus previous years. And so you see here, last year, or 3-year average was around 7,500, and this March it was 5,700. And whereas for February and January, there were few differences. So what's going on here? Because in high-income countries, as you've been following, there's an overall excess of mortality, for example, in New York or in London. So one of the concerns here is that this was broadly commensurate with when the lockdown was considered or was thought to be enforced. So did this lead to a large outmigration of the denominators of people that might have died? These aren't reductions from road traffic injuries, because those are only about 10% of deaths in India. All injuries are only 10% of deaths. So the reduction here is not because people are getting less killed by injuries. But so this raises the concern: did large numbers move out from Mumbai to the rural areas? And now, under a lockdown situation, it would mean that, let's say, a migrant male from Mumbai would go back to Bihar, and if infected, would infect their family members. But because of lockdown, there wouldn't necessarily be community transmission. There'd be household transmission. So this is a very important dynamic to study. So what does this mean in terms of what we know for control? Well, first, as Shamika pointed out, for community transmission, there is some control. Another really key element which gets less attention is what's happening in facilities and hospitals. So in high-income countries, in Canada, in the US in particular, 75% of the deaths that occurred were in long-term care nursing homes. And this is the big worry I have about India, is whether enough efforts and surveillance is in place to prevent a large increase in the facilities. Now, the third element, of course, is this needs to be a global battle. If infection is not controlled in one large country, as economic activity opens and you get migration and remigration, then you might get an increase again in cases. And Singapore is facing this to some extent. And I very much endorse the idea that a massive increase in testing and contact tracing is needed. And then full details, like Singapore has, of all those that are tested. And I think the right kind of scale to think about would be something like 1 billion kits for India. The Indian testing strategy has really improved. They used to be something like 500-fold lower than than South Korea. And now it's about 12 or 13-fold lower. So that's the improvement in testing is welcome. In the facilities, full protective equipment for all staff and separation of COVID, non-COVID has to continue and probably will be the new norm. And finally, let me turn to the implications for what it means for science. So first is to recognize that we shouldn't assume that this will be the only peak. As we know from influenza, it had 3 major peaks. The first small peak, which was somewhat driven by the actual infection, and then the big peak at the end of 1918-19, which was driven by return of soldiers after World War I, and then a later peak. So is this going to be the pattern that we face? We don't know. SARS, for example, only had one peak, but COVID might well have multiple peaks. So what do we need to know in terms of mortality? Well, first, in urban areas, I think what Mumbai has done and some municipal corporations have done is absolutely vital, is that they should release all the existing weekly data on what are the death totals, all-cause death totals, and where available, cause of death. They have them in the medically certified causes of death data, so they need to really expedite and release weekly data with comparisons to the past. In the rural areas, the concern is there hidden infections and deaths? You have to remember 80% of deaths occur in rural areas, and 80% occur without any medical attention, meaning basically someone dies without going to the hospital, and they can be cremated very much in the open field in the back or buried in the back. So we don't have the registration systems like exist in Mumbai. So I believe a very practical solution there would be for the Indian phone companies to release on aggregate the phone data as to where people used their phone and where they're using it now in the months of basically by week. And then you'd get some sense of what has been the out-migration. And then in the areas, in the urban areas, but also in the rural areas, update the million death study approaches. Now, the million death study involves a partnership with the Registrar General, where we surveyed 1 million homes all over the country, knocked on doors, implement a simple 2-page form that asks about symptoms, and then 2 physicians determine the cause of death using online efforts. Now, the last time the Registrar General has done the million death study results is for 2015, but I believe a urgent survey is needed to compare the first few months of 2020 with the last 6 months of 2019. And if that were done in the urban areas and in the out-migrant spots, so you don't need to cover the whole country, you can get maybe a few thousand sample areas, that would give very good information. And if that confirmed that in fact the deaths are low from COVID, as many have suspected, then that's important not just for India, but it's important for the world to understand. If death rates are low, then there are some factors in the Indian population that await discovery that might be very relevant to vaccines or understanding risk factors. Finally, the last 2 points I think that are important is there's a very simple thing that can be done. Every district has a mortuary, and because of police investigation or FIRs, deaths have to undergo an autopsy. So the simple thing is swab them, just have some of those kits available. And for every district, you'd get some sense of whether people, let's say, killed in road traffic injuries or found dead on the street or even murdered, what is the prevalence of infection in those populations? And that would be very useful information. And then the key thing, of course, is to know the denominator of those infected. So in Canada, the estimates have said that something like 13 times the number positive are actually infected. So we've got something like 60,000, close to the Indian numbers of 65,000 infected. So this suggests perhaps there's close to 1 million Canadians actually infected, but only 65 testing positive. In some surveys that have been done, serosurveys, they've found about a 10-fold higher, at least, prevalence of infection versus the actual case reports. So what we're doing in India is what's called the Action to Beat Coronavirus, or the ABC study. And the idea is to take a random sample of Canadians, send them a kit at home where they do a home blood sample and they mail it in. A really simple idea. And then you test to see whether there's antibodies, and then you can repeat the testing to see if this has occurred. And the key importance of this is a random sample. And this is really needed in India, is to get a good sense of the underlying prevalence of infection. So let me conclude. We need more science. We need to know how many more infected. We need to know why some die and others don't. And then obviously there's treatments and randomized trials underway. And to reopen the economy, very much the core strategy has to be to protect healthcare workers and longer-term homes. That's a big lesson learned from high-income countries, is not to go down that disaster route. And then that's paired with a massive increase in contact tracing. I'll stop there.
Thank you. So I read something interesting as, I was preparing for this conversation, and I think Shamika and maybe Prabhat, you can also speak to this. The West Bengal government did a survey, extensive door-to-door surveillance in April, I think of about 5.5 crore people, and they found 92,000 cases of influenza-like illness and 870 people with severe acute respiratory illness across the state finding. So the chief minister says that these are early, so it's like pooled testing. Could you speak to that a little bit for India? Because not everybody could be tested, I would imagine. Testing 1 billion people would be a challenge.
Yeah. I think that's a very good point, that, and a lesson learned from China is that you can use syndromic surveillance, basically going out and asking if people have presumptive symptoms. I'll just give you a quick little anecdote about how effective that is. So my colleague Rajesh Kumar at PGI was in charge of, as epidemiologist, in the 2001 plague outbreak in Himachal. Having learned from the 1994 plague outbreak where it was a disaster. So what did Rajesh do? Well, he looked at some of the numbers. He got really concerned. He called the chief minister on a Saturday at a dinner party and said, "You've got a problem." The chief minister was really annoyed, but he said, "If you don't want to sue it, then listen to me." And he said, "What do you need?" He gave Rajesh about 300 staff, police officers, contact tracers, and they went and syndromically found anyone who was infected or seemed to have symptoms and did contact tracing. And basically under police force, without any testing, but just based on possible syndromes, the epidemic was shut down. So I believe a similar strategy is actually worth considering. Ideally, you'd want testing, but even with that, syndromic surveillance and facilities and money that lets people stay at home to say, and then do effective contact tracing. India has a strong record of this. It's got an effective polio program. There's a large cadre of polio officers. They can be mobilized precisely for these kind of efforts. So I applaud the West Bengal government for doing that.
Shamika, did you have anything to say on the West Bengal government? I can't hear you. I think
you might be on mute. Yeah.
Sorry. As of last 1 week, the West Bengal government has done considerable revision to the case count as well as the death numbers. So I think it's very important to have early warning symptoms, early warning systems in place of the type that Prabhat was speaking about. But currently the management of the problem in terms of containment of this infection, it doesn't seem to be working very much if you consider the exponential growth that in active cases that West Bengal is seeing. But where I can definitely attest to what Prabhat is saying is from the Kerala and Haryana experiment. That, in Kasargod, which had 100 cases, it was the hotspot, the first hotspot before anywhere else in the country. When Kasargod had 100 cases, they had done contact tracing of over 20,000 people. When Bombay had the same number, they had done contact tracing of little under 7,000 people. Now that just tells you the kind of the scale and the management that is required to really get ahead of this infection. So I do think that at the local level, they really have to get civil administration, the public health, and the police. The police simply because they have the manpower and they have the natural training for contact tracing, right? The whole debriefing, verifying through call records, what Prabhat was speaking about. They have access to that information. And I do know that the Kerala government, because we've just written a case on that, they did go about doing that. So did Haryana government. So any government which is sort of ahead on the management side of it truly has, I mean, they're all struggling because it's not zero yet. But there is a plan, and that plan seems quite comprehensive.
Interesting. But it's a difficult situation for everybody. For instance, when numbers get bad, ICMR, for instance, no longer providing, I think, an evening update. UK is not sharing recovery data. And when Singapore saw a spike in cases, the time of the daily announcement came late at night. Now they've changed their strategy. They announce it at midday. So the government's in a difficult spot when they have to share, say, negative data. But you do need to be transparent about it. So how do you ensure that the governments come out and, speak the truth?
Well, I think civil society pressures that the data, all of the available data should be available with obviously protection for individual identity. And Singapore was actually quite an exemplary nation in terms of releasing full details on the cases and possible contacts of those cases and locations. And I think that kind of effort is needed. But in addition, the institutions of the country, not just the government institutions, also need to be very much demanding that these data would be available. The lesson is very clear that if you try to bury the truth, it'll just come back and bite you. And I think governments do realize that. And the other part of it is to get public confidence for people to go back to work, exactly as you're saying. How comfortable would people be taking Mumbai public transport? The communication of what we know, the very clear, calm scientific communication is a key part of control. It's what gets public confidence that things are working and that there are improvements and that the risk of transmission for individuals, particularly younger individuals, is quite low. So it's an essential part. And certainly the idea that somehow the authoritarian regimes are better. Well, the trains ran when Mussolini was in power on time, but you don't want to go back to a Mussolini time to control the epidemic.
Yeah. Shamika, any thoughts on that?
I agree. I completely agree with him. In fact, you're right. I mean, ICMR did put out some information. I think in many ways, Bunty, this is also a test of capacity of the existing institutions. Right. We do have a great history and sort of traditions of surveys and data gathering, but not of the magnitude and real time requirement which we are faced with today. And it's very clear. That's why, in fact, almost all the analysis that we are doing is dependent on publicly available data, either from Johns Hopkins or I think, the bunch of youngsters, what they've done through the COVID19.org, they've done a phenomenal job of verifying and sort of putting daily data from across the states as disaggregated as they can. Now, what they're also good at, because I constantly keep questioning them because they do occasionally miss, but that's the nature of the beast. I think the more transparent we are, the more confident we are of exactly what is happening. And for instance, I mean, besides Singapore, I think Germany has done a very good job as well. In fact, we just published a paper last week looking at German data because they are putting out highly disaggregated data. And some of the findings are quite fascinating if we consider the increasing mortality gaps between men and women for all age groups. I mean, it's an astounding finding because not only, we did know that it has differential impact on the two genders, and people have attributed this try to explain this through smoking habit, etc. At least in China and South Korea, etc. But Germany is a curious case where smoking habits aren't that different between genders. You have 25% and 32% smoking habits, and yet mortality numbers wide gap and increasing with the pandemic. So this is all knowledge. I mean, we don't have answers as to why that might be happening. It will require far more scrutiny. But the first step is to really get the data.
Yeah.
Okay. Did you have a question for each other? Did you want to ask Shamika a question, Prabhat, or?
No, I'm delighted to hear an economist talk like an epidemiologist. So welcome to the club.
Thank you, Prabhat. But I have a question for you. And I'll tell you, this is generally something we are struggling with. Because a lot of the epi models that we try to use in the beginning to get a handle on what things are, how things are here. A lot of the parameters are not estimated using Indian data.
Yeah.
Do you see any efforts in the last couple of weeks to plug that gap?
Yes. Well, I think it relies on having better details of the testing data. So even, for example, the time between symptoms and testing, the demographics of who is tested, all of those, if they were released, would be extraordinarily helpful to modelers and to epidemiologists. Better mortality counts, daily mortality counts from the places where registration is good. For example, Mumbai and in Calcutta and others would also be important. And one of the things I was very much hoping for, which it's starting to happen, there's some papers on medRxiv of the Indian tremendous ability in mathematics to try to get real-time estimates of effective or not done based on the testing data for each state. That I think is quite important. So it's starting to happen, but not quickly enough. I agree with you. Some of the early estimates, for example, what my friend Ramanan Lakshminarayanan put out, were really quite off. I mean, the assumption that India would have something like a million deaths by now were really quite off. But he's not the only one. Neil Ferguson and others in the UK really made very wrong projections, but it was because the data were insufficient. So this is where a deliberate effort to try to get data publicly available, I think will help. So, Bunty, I see there's a few questions on the chat.
Yeah,
so we should
I was
probably
just going to go to. So there's a question from Mudit Jain, and I'm going to put it together, which is, one is, he talks about that, how can you trust data from the government, and are there any other indicators that you can use? And the second thing he says is that the government copies the other countries for installing traffic signals, etc., but they're not really helping people. So will it lead to social unrest in India? And then I can read you another question. Shamika, this I think, these are kind of targeted towards you. Suman Berry asks that what is the correct balance between national directives and local initiatives? Was the West Bengal Chief Minister right to object to a visit from the center?
Well, we are a very large, complex federal country, and I think given that health is a state subject, I think eventually the states and districts which do have the capacity to manage the situation over and beyond the center's directives. I think the center has an advisory or a guiding role to play in this. And of course, the testing, it's all ICMR labs, the confirmations are all happening at that level. But a lot of the actual implementation of whether it is contact tracing or the containment strategies, they're all very much localized. So it will take efforts pretty much bottom up. And I think over-reliance on the center, I don't think is the right way to go. If we consider that the states which have done a good job, and it's too early to say, but the ones which seem to be ahead of the infection are the ones which do have local capacity, which do have good local public health infrastructure, which seem to have stronger data systems. So eventually, I think it will be local institutional capacity more than at a national or a central level.
Yeah.
Okay. Uh, so somebody, Sophia asks of all the panelists, thanks for the conference. What proportion of COVID deaths do you estimate to be outside hospitals?
Well, we don't know that because we don't know the denominator. But if you look at, let's say, the last round of the million death study and ask how many pneumonia deaths occurred in India above age 20, we estimate about 160,000. And 80% of those were in rural areas, and 80% of them occurred outside of hospitals. So if that's comparable to the outbreak, it's an argument for really getting a good understanding. But because it's an epidemic, then what's needed is not truly a random sample of all the deaths, although that'd be ideal, is a more focused effort. Go to the urban areas and then find the places where migrants have moved and go to those villages and do a survey. And that's very much what I've suggested that Mr. Joshi, the Registrar General of India, tried to get organized quickly, because that would give good information. They have the infrastructure to do so. It's just a question of the political will to implement.
Inakshi Sopti asks from Bombay, doesn't Mumbai need to address the issue on a war footing? Does it merit getting the army involved to start doing the extensive contact tracing required in Mumbai?
Oh goodness, no. Get the police, as Shamika said, to do their job.
Okay, let me just go to this. I think there are some Q&As as well. Let me just get to it. So somebody asks that, they ask Dr. Jha, you mentioned home test kits being sent out to people in Canada. How were the number of kits decided?
Well, we did a sample size calculation. My guess is that the prevalence in Canada might be around 3% of people or of adults being infected. If based upon that, we made a crude sample size calculation of you need about 10,000 people tested. That's probably going to be too small because you want to look at focal differences. So Toronto might well be different than other settings. The implication for India would be to try to get a reasonably quick survey, but again, with an overemphasis on the high clustered areas that have been identified in Shamika's graphs, and then some random sample of the rural areas. And this is very much possible. You can send either kits or you can send teams. The video is very simple to explain, and have them sent back to a central lab. The Tata Memorial Hospital has a beautiful central lab, for example, that could receive these samples. And then you'd get a real snapshot of what is happening with the numbers of denominators. And that in turn is crucial for a key piece of information, which is the infection fatality rate. And in the absence of good infection fatality rate, so many of the models have got things wrong as to what's actually going to happen in India. So this is a very feasible strategy. And now it sounds silly to say, why do you need research in a time of a pandemic? Well, you know, in a time of cholera, you don't just need love, but you also need your brain, and you need to do some science to try to control the epidemic.
Right. So are we living with the pandemic, or are we overcoming it?
I think it's mixed. It's very much, as Shamika nicely showed, in some places there is very good success. In Canada, we've got now parts of the country that will open up. Where you have science-based decisions, for example, Austria, Germany, in Vietnam, others, that we've actually got hopeful signs of progress. But I'm afraid the political discourse and the dominance of the US media in showing just the absolute catastrophe south of us, the public health catastrophe, is hiding the fact that within the US there are successes. Washington State went from being a hotspot to really having effective control. But of course, you have so much media attention on what's happening in New York. So I think getting people's confidence that we know how to control the epidemic if you use science and contact tracing and testing and good basic common sense is going to be key to have the confidence for us to feel safe to go back to work and to get on public transport. So it's every government that says, oh, well, we've got this under control, trust us. That's exactly the opposite that happens. People don't trust you if you say that.
That's right. Do you want to say a last word, Shamika?
Well, Bunty, I do think 18 to 24 months is what we're looking at. The reality is also that we are not an OECD country. We truly are. We just got off the sort of the poverty line. And I don't think we can continue this extended lockdown. And I think from that perspective as well, doing more testing is just knowing more. So if we open, let's say 300 districts where we have 0 reported cases, let's just confirm it and then open up. Because I do think from the economic point of view, we can't afford to see a major decline. When over the last 30 years, we've struggled so hard to bring millions of people out of poverty.
Yeah, yes. Thank you. So thank you for a most educational and interesting evening, and I think full of learnings for our audience. And so thank you for taking the time, and we look forward to connecting with you at some future date when things are better.
Thank
Good night.
Thank you. Stay safe. Bye-bye.
Bye.